Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey, CEimpact subscribers. Welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard. And today we'll be talking about new evidence that's raising questions about the role of tramadol for chronic pain. We know chronic pain is common and often difficult to manage, especially given concerns in recent years about the use of opioids. Tramadol is often thought of as a safer opioid option for treating pain, and it's one of the most commonly prescribed opioids in the US. But a recent systematic review and meta-analysis is calling the role of tramadol for chronic pain into question. So we're going to dig into this evidence and discuss whether it's practice changing and then reassess where tramadol fits in for managing chronic pain. So to help us get to that bottom line, I'm so pleased to welcome our guest who has special expertise in pain management, Dr. Emma Murter. So welcome, Emma.
Hi, Rachel. Thank you so much for having me today on the podcast.
We're super excited to have you. And thank you so much for taking time out of your busy schedule to be with us. But I know this topic is of interest to a lot of people. So happy to have you and to hear your expertise. And to help our listeners learn a little bit more about you, could you just share a little bit about your background, your current role, and why you're interested in this topic?
Absolutely. So I did a couple of residencies. My first one was at Billings Clinic in Billings, Montana, in practice management. And then I did a pain management and palliative care residency, PGY2, at the University of Iowa College of Pharmacy in Iowa City. And I am currently the outpatient chronic pain management pharmacist at Intermountain Health in Salt Lake City.
Well, that's a perfect fit for this topic, talking about chronic
Indeed.
pain. So you have a lot of real world experience with this, which is great.
I do.
All right. Well, excellent. So let's just jump right in. I mentioned that I think people often do think of tramadol as a safer option and may sort of reach for it when you don't want to go to something like morphine or oxycodone, some of those full opioids. And so is there any truth to that concept about whether tramadol is a safer option and why is it seen that way?
I think probably the first reason it's seen as a safer option is probably prescriber habit, right? It's a controlled 3 versus a controlled 2, which means things like it can have refills on it, and just that lesser schedule means it's seen as kind of like more accessible, that safer option. Clinically, kinetically, tramadol is kind of an interesting medication in that parent compound tramadol is actually a serotonergic medication. It then undergoes CYP2D6 metabolism and becomes O-desmethyltramadol, and that is actually the opioid. So that's actually the opioid component of tramadol, and that's when you get the opioid activity. So I think that's probably how it was first kind of thought of as safe, is you get kind of, first pass metabolism and all of that, you get like less opioid for the milligram that you're taking. There might be concern for, especially 2D6 being one of the most polymorphism phenotype CYP enzymes that we have, how much opioid, how much O-desmethyltramadol do you get? Do you get a lot? Do you get a little? That's kind of the question with tramadol.
Yeah. So you highlighted a few things there. It's I think the scheduling is a really important concept, and it does definitely contribute to that perception of it being potentially safer. But as you said, it still binds opioid receptors and has opioid activity. But the extent to which that might occur also depends on individual metabolism of the drug based on that those polymorphisms, as you said. So interesting concept there to be thinking about. Some people may be getting more or less of that opioid effect. Is that right?
Correct. And, when we think about patients who maybe have differing liver function, it's hard to determine in the setting of, hepatitis, which enzymes are affected first. But it's typically, CYP2D6 is kind of like our canary in the mine because it's so many drugs go through CYP2D6. So it can sometimes be that enzyme is our hallmark signature of, hey, there's something going on with metabolism. And with tramadol going through there, I get really concerned when patients have any sort of liver dysfunction going on and the use of tramadol in those patients, because if CYP2D6 slows down, we're getting a ton of buildup of serotonergic effects, which has its own concerns and potential benefits. But on the other side, if we've got really, really fast CYP2D6, they could be cruising straight through to the opioid, which could potentially lead to opioid toxicity. And the reality is, it's so hard to predict.
Right.
In the world of chronic pain, we sometimes call this like dirty pharmacology, and it's not a bad thing, right? Because chronic pain, it's not more acute pain. Chronic pain is maladaptive pain signaling. It's no longer a beneficial danger signal. It's now maladaptive. It's no longer benefiting the patient.
Right.
And we want dirty pharmacology. We want those receptors to be hit from multiple angles, from multiple pathways. We want that in an effort to kind of help pain in multiple ways. So tramadol is not the bad thing here. Also, moral assignment of medications is not the role here. But, tramadol, where the worry is how do we predict safety when the components of it are hard to predict, the percentage, quantity, the quickness. It's challenging to predict in the setting of really standard patients to any sort of dysfunction.
Yeah. And I think it's also important to highlight and reiterate that point you made about the serotonergic effects of it too, because that, as you said, dirty pharmacology, maybe that's providing some benefit in managing pain theoretically, but also increases risks of interactions and also with 2D6, interactions there. I think so. And I do think many of us probably think of tramadol as a common drug that we get those interaction alerts with, and a lot of these patients may also be taking SSRIs or SNRIs and at risk for serotonergic effects with all of those. So I think, generally, to summarize, it sort of has all the similar risks of opioids in terms of CNS depression risks and sedation and all of those effects, but also the serotonergic concerns come along with that too because of the mechanism. And so that scheduling doesn't necessarily mean it's safer. It may have different also concerns than some other opioids. So where does it currently fit in? We'll talk about this new study, but where does it historically fit in terms of managing chronic pain, and when would you reach for it?
So I feel like where it fits in currently for chronic pain is, again, kind of habit. When you have a Schedule 3 substance, sometimes it's nice to be able to put refills on there. It's kind of a more accessible opioid option for a lot of patients because there are a lot of rules around opioid prescribing. I feel like where I clinically reach for tramadol is when I have a patient who has neuropathic and opioid responsive components to pain. Again, that dirty pharmacology, that potential like nociplastic components of pain where there's some neuropathic elements. I'm focusing on function versus pain. So maybe I'm using tramadol to help them do physical therapy for a little bit longer to get them to be more functional. But I'm also understanding that there's like neuropathic components that may be like burning, electric shocking. I maybe am not reaching for tramadol if it's just neuropathic, and I maybe not reaching for tramadol if it's just nociplastic. But if there's like that true functional component that is kind of like opioid responsive, and I need that like little extra oomph that I would get from like a little opioid response, again, because tramadol is like, how much opioid are they getting? So just that like little opioid push to maybe help them improve their function. That's where I'm thinking, is tramadol a potential option?
Okay. That makes sense. And so let's talk about the new recent study here, because might be something that people have heard about or may come up over time, as people hear many patients are on tramadol. So I think it's good to look at the new evidence as it comes out. And so what can you share about this research?
Yeah, so this was a really interesting study. It was done by a Denmark team, and they did a pretty substantial meta-analysis. They looked at 19 randomized placebo-controlled trials, which ended up having over 6,500 patients. And the cool thing is that they were able to pull it all down to that numerical rating score, or the NRS, like a 0 to 10, so like 11-point NRS tool, which is really helpful when we're thinking about pain, because it's something that we can all, as pharmacists, pretty quickly evaluate when it comes to like pain. And so they looked at these 19 studies, and the very impressive thing I thought about this study is they looked at all chronic pain, and they include cancer pain, neuropathic pain, somatic, visceral. It was the breadth of chronic pain they looked at. Was I was impressed by that. I feel like there's oftentimes in pain management studies a lot of exclusions, which can make the real world application of some of these medication studies challenging. And so I was impressed by that. What they found after evaluating the literature was that tramadol had, compared to placebo, greater than 1 point improvement in the NRS compared to placebo. So they had their conclusions were that had like a mild to moderate like improvement in pain, but when they looked at side effects, it was like a moderate causing of multiple types of side effects, from your typical opioid responsive side effects to mostly the opioid side effects like sedation and things like that, which for anyone who's ever worked with opioids and chronic pain probably isn't too surprising with either of those results.
Sure. Yeah.
Yeah. I think the interesting thing was that they also looked at quality of life, and not all 19 studies looked at the quality of life. They only found 5 that did so. And they found mostly that it was really hard to report that tramadol really improved quality of life. And for those of us who work with opioids and chronic pain, we know this to be true as well. When we use opioids for more than 12 months, there's no evidence that opioids improve quality of life in the setting of chronic pain, which is unfortunate, right? Because chronic pain is not just physically exhausting and hard, it's mentally and emotionally very, very challenging. And so, not to digress slightly off of this study, but I think this study highlights that chronic pain cannot be treated with tramadol or medications alone, right? We need multimodal therapy for chronic pain.
Yep.
We need pain psychology. We need physical therapy, right? We need those other columns of support in chronic pain. But yeah, this was a fantastic study.
And so in terms of a bottom line, given the mild limited benefit for pain relief versus the risk of harm, my understanding is that the authors were sort of concluding that tramadol should be reconsider the use of tramadol for chronic pain. If you're already using it for chronic pain, consider the potentially limited benefit against the balance of potential side effects. And they also called out some interesting serious side effects like cardiac events and even cancer events, but questionable about whether there was a direct, theoretical link for why that would be. And I did find those safety considerations interesting, because why do you think tramadol would be connected to some of those particular risks that they called out?
I suspect that tramadol is probably linked to some of those side effects, not because of the opioid component, but probably because of the serotonergic component. Because again, that tramadol is the serotonergic component, and it then has to go through the liver to become O-dis-methyl tramadol. And I think when we think about the risk of opioids, we're often so focused on the respiratory depression and the constipation, and we're not often thinking about what are the other components. Like when we even think about hydrocodone, it's always combined with acetaminophen, right? I have to highlight with all of my learners, hey, sometimes it's not even about the opioid toxicity, it's about acetaminophen toxicity.
Sure. Yep.
And we have to think about the long-term side effects of opioids as well, right? What are the endocrinopathies? What are the risks to bone mineral density? The Cancer Association, that one I am not entirely sure. I wonder if that was maybe an accidental correlation. They did have cancer pain included in the study.
Sure.
That one I'm not sure if I can entirely link based on the mechanism.
I know. And even the cardiac events, I don't know that there's a clear mechanistic association there, even, with tramadol, but interesting again to sort of see, okay, there is this association. We don't know if there's a cause and effect sort of relationship there, but at least that was part of the safety benefit risk balance that they were considering when sort of coming to this bottom line that tramadol should not be a first line option for managing chronic pain. And in terms of whether this evidence is going to change practice, Emma, what are your thoughts on that? How are you going to take this information and apply it to your practice? Is it going to change what you just shared about where you think about the role of tramadol?
Yeah, so I think I agree and will encourage anyone to not utilize tramadol as a first line option, because that also is in agreement with what few guidelines we have for pain management. That is an agreeable statement to that, right? The WHO pain ladder, opioid medications are not the first rung of the pain ladder, right? That's your potential lifestyle management, or like your NSAIDs, acetaminophen, neuropathic pain, right? You're looking at your gabapentinoids, low back pain, NSAIDs, acetaminophen, right? You're going to always choose conservative options. Tramadol should never be a first line option for pain. Should it be second line, third line? I think this study highlights that there are potential side effects and concerns with tramadol, whether it's the serotonergic or the opioid component, or really just opioids in general. There are side effects that need to be considered independent of just pain that are probably patient specific. And that's true of a lot of persons with pain. You have to take, and I know this is kind of a frustrating component of doing pain management, is you have to take the patient as an individual.
Yeah, absolutely. And to just emphasize, I think you just made a really important point about those non-drug options, those first line options, physical therapy, all of those components. We've obviously seen a lot more emphasis on all of that in recent years. And so this, again, just sort of drives that concept home too. I think it's a good opportunity to reemphasize those first and foremost. But then, as you say, individualizing, if you are thinking about going to an opioid, whether it's tramadol or another opioid, all of those factors you talked about at the beginning of the podcast are going to come into that consideration too. The nature of the pain, the patient, their comorbidities, or their medications, all of that is going to be super important in terms of individualizing. And so I guess if you're thinking about, if you are at the point of considering an opioid, is it just consider all of those factors? I mean, is there anything else that comes to mind about weighing tramadol versus another opioid? Or I mean, you've very nicely laid out the practical aspects, the neuropathic pain components, the serotonergic medications they might be on, the liver component, any other factors that we should be thinking about, especially. Yeah.
So, another common medication I like to use in my practice when I get to the point of considering an opioid is buprenorphine, because it also has some opioid receptor, absolutely. It's partial antagonist of the mu opioid receptor and an antagonist at kappa and delta. But it also has some theorized serotonin activity. So what's the difference between buprenorphine and tramadol? Well, if I have a patient who has constant pain, I'm probably reaching for something like buprenorphine because it's a long-acting medication. If I have a patient who has frequent pain or maybe has pain surrounding physical therapy, I don't want a long-acting. I want a short-acting,
Right.
and so I'm reaching for something like tramadol.
Okay.
Yeah, and or if they're on a ton of other serotonergic medications, maybe for concomitant disease states, I'm probably not reaching for either of them. And if I
Right.
absolutely have to use an opioid, maybe I'm reaching for something like a low dose hydrocodone or a low dose oxycodone or something like that. There is a time and place where you want dirty pharmacology, and there is a time and place where you
Right.
want clean.
Right. Yeah. I think that's a great way to think about it. And it's unfortunate, you want to be able to give black and white sort of recommendations, and it's just not that simple. And there's so many
Yeah,
factors that come into play there.
I know. That is one of the reasons I love doing pain management. I tease my other pharmacists I work with. I'm like, no one can tell me what to do because I have to like see the patient as a whole, right?
Yeah.
I have to kind of like check in with their psychological safety and their home safety, and I have to like check in with my community, right? And their community. And I have to see them as a whole person, their emotional,
Mhm.
mental, physical state. And I have to take
Mhm.
all of that into consideration as I come up with a plan for my entire pain management team. And I have a whole team. It is not just me and a provider. It is a whole team, and I'm so, so thankful for that.
Yeah.
Because it's really important to have that when you're really trying to get after chronic pain. Um, and I'm like, if I had to just follow the ADA guidelines for insulin dosing, I think I'd lose my
So the
mind.
gray, you like the
Yeah,
gray
I
and
love the gray. Thrive in the gray,
yeah,
which
yeah.
makes it hard when I'm trying to give advice to my other pharmacists when they have,
I
and even
know.
on this podcast too, when I'm trying to give advice for like when and where is
Right.
tramadol, and it's like you need to look at
Right.
everything and kind of if the puzzle piece fits, or even if it kind of fits, sure. If there are glaring, jagged corners where the tramadol just isn't gonna fit, don't do it.
I love that analogy of the puzzle piece. That's a great way to think about it, because as we talked about all of those jagged edges and how they might impact when you're thinking about it or not. And so does it fit in that puzzle piece of jagged edges potentially fit in with your patient's framework or not? That's just a great analogy to think of. Yeah, I love that. So say you have a patient who's been on tramadol for some time for chronic pain. How often are you reevaluating that? And how often would you recommend all your colleagues in various settings be looking at those refills, for example? What are the sort of touch points that you want us to be thinking about and talking with the patients about and reassessing the patient for? What are those follow-ups look like?
That's a really great question. So I would say for those patients that have been on tramadol for, you know, years, months, you know, I would say I'd still want to probably check in with them every 6 months at minimum, just to make sure that we're encouraging and pairing that with some sort of functional component, right?
Mm-hmm.
Are we still using the tramadol to walk the dog, to go to physical therapy, to do the things that actually improve quality of life?
Mm-hmm.
Um, for some of my like new start tramadol patients, I like to do monthly and maybe push it out to every 3 months, again, to really promote, hey, this medication isn't just for you to have pain relief and then like sit on the couch. This is to have pain relief have function. I
Right.
like to tell my patients in the nicest way possible, I don't care about your pain. I care about your function.
Yep.
Because like I'm not going to cure pain. Medications don't cure pain, right? But medications can help with function. And so what is going to actually really help with function? Physical therapy, psychology, those potentially like interventions, like those things that are actually going to get them moving, get them stronger. And so I use medications to promote those. And if my medications aren't doing that, then I'm asking my patients and myself and the team, what's the point? And I have those challenging conversations, and sometimes they're really, really, really tough to have. And sometimes you have to have them a couple of times.
Yeah.
But,
Yeah.
it's ultimately checking in and making sure that, those medications are still appropriate in that, are they doing the things that are actually meaningful?
Right.
And, there was a great study called like The Name of the Dog. And I love that study because it actually is so, so important. You know, are they doing the things that's important for them? Are they walking their dog? Are they seeing their family? Are they getting on the floor, hanging out with their grandkids? Like those are the things that make our
Right.
patients who they are, right?
Yeah. I mean, I think it's such a really, that reminder needs so much emphasis. The fact that these pain medications are not going to necessarily stop your pain. And the goal is to improve your function, improve your quality of life, allow you to do the things that you gave beautiful examples of, walking the dog, hang out with your family, and setting that expectation up front. I'm sure you have to do a really good job of that when it's first being prescribed as well. And then, as you say, early on, having those regular touch points and ensuring that patients are continuing to see those benefits. And if not, especially over time, especially if it's been a while, it's a good opportunity to reevaluate that and have those discussions ongoing to say, okay, well, if you're not seeing that benefit or being able to go to physical therapy with the assistance of this, then it's not serving its purpose, right? So just such a good reminder. And I think pharmacists in any practice setting can be having those conversations and reevaluating, because often it's one of those things. I think pharmacists that's where we're focused, is medications. And so we might be the only ones sort of recognizing, oh, this patient's been on this long term. Maybe it's time to check in and reevaluate how it's going.
Absolutely. Yeah. Absolutely. And this is where I 100% rely on my like community pharmacy colleagues, right? Where I'm like, hey, you might be seeing my patient more than me functionally, like out in the wild, because I do a lot of telehealth. And like, how are they looking? How are they acting?
Yeah.
Absolutely.
Yeah. Well, and again, it's benefit, but then also the balance of benefits and risks too, because maybe something has changed in their med profile or their medications or anything else in their life. And you summarize that again so well previously in terms of all those factors to consider, and the balance can change. So what might have been good a couple months ago may not be good now. So just think it's a very key consideration. And yeah, I think keeping all of those things in mind when talking with patients, whether they're a new start or starting it, continuing it for some time, really important factors to be considering. So Emma, this is great. I thank you so much for your summary of the new evidence, figuring out that it's not really necessarily practice changing. It's sort of what you've already been thinking about for some time, but reinforces that consideration of potentially limited benefit given some of those safety considerations, but also individualizing that care is the most important thing, I think, for our patients. And maybe this gives us an opportunity to have some of those conversations. But it is our Game Changers podcast. So we always wrap up with what you think is the game changer that you want our listeners to walk away with. What is the thing that pharmacists can apply today in their practice from everything we've talked about?
I think my biggest ask would be, if you have a patient sitting in front of you with pain, checking in, treating them with empathy, and really acknowledging that multimodal component to pain management. it's not going to be just medication, certainly probably not just one medication, but that functional physical therapy potential component of pain really, really is the ticket to chronic pain management, is that multimodal component.
Absolutely. I love that summary. Great bottom line. Thank you, Emma. And again, thank you so much for taking the time to share your expertise. You got a lot of practical experience to bring to this. So I learned, and I hope our attendees did too, our listeners.
Thank you so much for having me, Rachel.
Excellent. Thank you. And listeners, we talked about a lot of great practical tips today. These will all be summarized in the practice resource that goes along with this podcast on the CEimpact website. And be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.